Septic shock is a biological countdown. The moment an infection breaches local containment and enters the bloodstream, the microvasculature begins to collapse. With every hour that definitive treatment is delayed, the probability of death sharply increases. The underlying definition established by Sepsis 3 remains completely intact. It is a life-threatening organ dysfunction caused by a dysregulated host immune response to infection. What has changed is the clinical playbook. The 2026 guidelines demand a departure from legacy protocols, abandoning rigid, high-volume resuscitation. In its place is a framework built on 3 calibrated pillars: precision hemodynamics, altered vasopressor escalation thresholds, and updated antimicrobial pharmacokinetics. For years, the standard algorithm required clinicians to continuously push intravenous fluids to clear serum lactate. We now know this reflexive fluid loading reliably caused severe volume overload, leading to acute respiratory distress and secondary organ injury. Surviving sepsis in 2026 requires a high-wire clinical balancing act, eradicating the bacterial source with absolute aggression while strictly protecting the patient from the iatrogenic harm of the resuscitation itself. The most critical intervention remains the delivery of broad-spectrum intravenous antibiotics. The mandate is absolute. They must be administered within 1 hour of recognizing septic shock. The clinical data driving this timeline shows a catastrophic cost for hesitation. Every single hour of delay in antibiotic administration increases in-hospital mortality by 7.6%. To maximize the efficacy of these drugs, the 2026 guidelines introduce a major shift in pharmacokinetics. This chart illustrates plasma drug concentration over time. A traditional rapid infusion of a beta-lactam antibiotic spikes early but quickly drops below the minimum inhibitory concentration, or MIC. By extending the dose into a 3-hour prolonged infusion, the plasma concentration is maintained steadily above that MIC threshold for a significantly longer duration. Because beta-lactams are time-dependent antibiotics, their killing power relies entirely on sustained exposure. Keeping drug levels above the MIC longer continuously attacks the pathogen, while the patient remains in a hypermetabolic state. In practice, this means instead of pushing 4.5 grams of piperacillin tazobactam as a rapid bolus, you run it over a full 3-hour block. However, this aggressive upfront therapy must be coupled with an equally aggressive exit strategy. Antibiotic stewardship now demands rapid de-escalation the moment clinical data allows. This is achieved using pathogen-specific rapid diagnostic testing, like MRSA nasal swabs, executed immediately upon the patient's presentation to the emergency department. If that rapid swab returns negative for MRSA, clinicians can immediately pull back the broad-spectrum coverage, safely discontinuing highly nephrotoxic drugs like vancomycin. The 2026 antimicrobial strategy requires a deliberate paradox. You must initiate broad-spectrum destruction of the pathogen instantly, while actively hunting for the earliest evidence-based opportunity to narrow your attack. Once antibiotics are running, the focus shifts to restoring vascular volume. The baseline resuscitation rule remains intact. Patients exhibiting hypoperfusion require an initial 30 milliliters per kilogram of intravenous fluid within the first 3 hours. But the composition of that fluid has changed. The historical reliance on normal saline is now firmly rejected. Balanced crystalloids, specifically lactated ringers or plasmolite, are the preferred choice. High-volume normal saline consistently drives hyperchloremic metabolic acidosis and acute kidney injury. Balanced solutions closely mirror human plasma, driving down the incidence of renal failure and mitigating secondary acid-base disruptions. To identify the patients requiring this initial fluid, clinicians still look to lactate. An initial serum lactate level above 2 millimoles per liter remains a primary trigger, confirming tissue hypoperfusion. But the era of using sequential lactate draws to justify ongoing fluid administration is officially over. Lactate clearance lags behind actual hemodynamic recovery. Blindly pouring in fluid to force a normal lab value pushes volume out of the vasculature, leading directly to third spacing, widespread endothelial injury, and pulmonary edema. The decision to administer further fluid must now be dictated strictly by dynamic assessments of fluid responsiveness. Instead of a blood draw, the protocol relies on real-time bedside physiology. This includes monitoring capillary refill time, performing passive leg raises, and utilizing point-of-care echocardiography. These dynamic tools answer the critical questions: is the tissue actually receiving blood, and can the right side of the heart safely accept more volume? They tell the clinician exactly when the patient has had enough fluid. Shifting from a static lab number to dynamic markers of tissue perfusion ensures we treat the shock without inadvertently drowning the patient and triggering iatrogenic acute respiratory distress syndrome. When fluid resuscitation alone fails to restore pressure, vasopressors are required. For the general adult population, the target remains a mean arterial pressure, or MAP, of 65 millimeters of mercury. But this chart illustrates a major exception introduced in the updates. For adults over the age of 65, the target is now lowered to a permissive zone between 60 and 65 millimeters of mercury. Forcing higher pressures in the elderly population requires higher catecholamine doses, which provokes new-onset atrial fibrillation and excessive ischemic vasoconstriction. Lowering the target preserves adequate organ flow while reducing the toxicity of the drugs. Across all demographics, norepinephrine remains the absolute first-line vasopressor for septic shock. But the protocol for titration is now governed by specific dosing limits. You no longer push norepinephrine to its maximum allowable dose. Long before it reaches its ceiling, a second agent must be introduced. Specifically, when the norepinephrine requirement reaches between 0.2 and 0.3 micrograms per kilogram per minute, vasopressin must be initiated. By bringing vasopressin online early, you engage a completely different vascular receptor pathway. This creates a synergistic squeeze that spares the myocardium from the extreme stress of massive single-drug catecholamine doses. If the patient's blood pressure remains dangerously low despite these two primary agents, epinephrine is explicitly designated as the third-line therapy. Dopamine, once a staple of shock resuscitation, has been heavily deprioritized across the board due to a deeply unfavorable safety profile and a strong association with fatal tachyarrhythmias. By utilizing a layered multi-receptor approach, clinicians achieve hemodynamic stability far faster, avoiding the severe cellular toxicity of forcing massive volumes of a single drug. Beyond pressors, the role of corticosteroids in sepsis has been debated for decades, leading to wildly inconsistent application at the bedside. The 2026 guidelines clear this up with a strict rule. Corticosteroids must never be administered prophylactically to prevent a patient from deteriorating into shock. There is only one entry point for steroids in this algorithm, and that is refractory septic shock. Clinically, refractory means the patient is trapped in a state of unyielding hypotension, requiring escalating doses of multiple vasopressors, despite adequate volume resuscitation. Only at this stage is the addition of IV hydrocortisone recommended, dosed at 200 milligrams per day. And importantly, the data confirms that adding concomitant fludrocortisone provides no additional benefit. Corticosteroids are strictly a rescue therapy deployed to treat the stress-induced endocrine failure of profound shock, not a universal safety net. Managing septic shock requires navigating a constant operational tension. You have to treat the patient with simultaneous extreme aggression and absolute calculated restraint. The aggression is directed entirely at the infection. Broad-spectrum beta-lactams are initiated within 1 hour as prolonged 3-hour infusions, but you use rapid diagnostics to de-escalate the moment the data allows. You restore volume using balanced crystalloids, but you dictate the exact stopping point using dynamic markers of tissue perfusion, actively ignoring static goals like lactate clearance. And you defend the patient's blood pressure by abandoning massive doses of norepinephrine in favor of early vasopressin integration and age-tailored targets. This represents the evolution of critical care. We are leaving behind the blunt, one-size-fits-all bundles of the past and adopting precision physiology. To truly conquer sepsis, we have to respect the complex reality of a dysregulated host response. We relentlessly attack the invading pathogen while carefully shielding the patient's vital organs from the unintended collateral damage of the cure.